Care's Community Education Series panel event on perinatal mental health. My name is Robin Wagner, and I am the Nash Center Community Engagement Coordinator. I would like to thank each one of our panelists for sharing their personal experience on tonight's topic and taking time out of their busy schedules to be here. This is truly just the beginning of this work, and we at the Nash Center are excited to have you all here to be a part of this community conversation. At the Nash Center, we focus on creating a safe, inclusive place to heal and want to clarify the language that will be used during tonight's panel. We recognize that while typically those giving birth identify as cisgender women, that is not always the case, and we will be using the term birthing parent to identify those experiencing pregnancy. Before we get started on the rest of the event, I would like to thank Ameritrust Credit Union for sponsoring tonight's event and invite Tim Mock, Ameritrust Credit Union's Business Development Officer, up just to share a few words.
Thank you, Robin, and thanks for everyone for coming out. What a great turnout we have tonight. And thank you to our panel. I'm really excited to hear what you all have to say. So, from a Ameritrust perspective, we're just excited and proud to be a small part of what goes on in the mental health world that we have here in Florence. It's such an extremely important part of our social services that we offer here. And so anything we can do to help, please stop by my table. I have a few giveaway items. So please don't leave without taking something. So once again, thanks all everyone for coming. Thanks again to Nash for hosting this.
Before we begin with the question portion of the night, I'd like to invite each of our panelists just to share their name, where they work, and why they feel this topic is important to talk about.
Hi everybody, my name is Melissa Hoffman, and I think I'm going to answer those kind of combined, if you don't mind. So I currently work as a psychiatric nurse practitioner at LMH Health. I'm integrated in the OBGYN office, and I live there because I have a particular interest in reproductive psychiatric care, in particular perinatal mental health care. So I have some specific training in that area, and basically care for people menses to menopause and everything that happens in between is like how I like to put that. So I was kind of catapulted into the maternal mental health arena 18 years ago. I'm lucky enough to be a mama to an 18-year-old boy who just went to college and a 16-year-old boy. And at the time I was a labor and delivery nurse, I was a childbirth educator, I was a breastfeeding educator, and I'm very honestly going to tell you I was not aware of the intersect between mental health, maternal mental health, and the perinatal time frame. And so after my own experience, I set out to learn some more, and I became a volunteer for an organization called Postpartum Support International. Lucky enough to have become a state coordinator for them, which I continue today. I'm also happy to announce that almost 4 years ago, or 3 years ago, we founded the Kansas chapter of Postpartum Support International, which I'm very fortunate enough to serve as the current president of that organization. In addition, I started a organization or network here locally called Build Your Village with the help of some wonderful people who happen to be here today, where we offer peer support, connection to resources, and also a weekly peer support group. And so we're going on 15 years of doing that. And that's why I find it so important, because when I, 18 years ago, went through what I did, there was no conversation about this, there were no questions about this, there was no screening. And so now, as we thankfully are talking more about this, I recognize the need for continued peer support for the women who are experiencing this, and then also education for providers. As I continued in my role, I recognized there was a need to bridge that gap between psychiatric care and obstetrical care. And so when I went back to school and landed where I am, I continue to work on increasing provider capacity to identify and to treat these disorders. I'm lucky enough to serve as a perinatal perinatal mental health content expert for 2 HRSA-funded initiatives that are going on in our state. And that's really what we're trying to do. We're trying to bridge the gap. So that's why I do what I do, and that's who I am. I'll pass it over to Dr. Longman.
not near as cool as Mel. So I'm Dr. Lindley Holman, and I'm an obstetrician gynecologist just over at LMH Health with Lauren's OB/GYN specialists. And this is important because it is so widespread. And I think there's a lot of misconception about what peripartum mood disorders are. Because what do we see in the news, the women or people, parents who have catastrophic events, right? We read about the people that have killed their children or have died. Or it's a lady in a robe looking out, wishing she could participate in life. And that's not often what the peripartum period looks like. And so I think, people think if they don't fit one of those boxes, then it's something that they've just got to pick themselves up and move through. And, and my daughter's 11 and I had severe anxiety. And I knew it was happening. I knew it was happening. And I was interested in peripartum mental health even before that. But, I think it's not represented well. And so then people think that there are things that they just have to muscle through. It's just part of new parenthood or whatever. I also have a strong interest in health equity. And I don't think we can talk about health equity and I don't think we can talk about disparities in this country without also addressing trauma. And so that's kind of been my newest over the last couple of years. My newest lens is really trying to provide a trauma-aware lens and to bring that to our birthing center and to be very mindful of that and to help patients link up with tools that may help with those physiological responses to things that are so common, especially during the birthing process. That is a really triggering time for a lot of people. So that's why I'm here.
My name is Anna Palermo. I am a therapist here at Nash on our adult outpatient team. I kind of fell into perinatal work and an interest in the field in graduate school when I studied in Washington University in St. Louis. I picked a practicum that was called Perinatal Behavioral Health Service, and I was just thrown into this new world where I could see this intersection of medicine and mental health in such a fascinating and front row view. I got to have experiences in the OB clinic, kind of seeing the outpatient side of folks navigating the pregnancy piece or fertility piece. I had some experience on the postpartum floor, seeing just that deer in the headlights look with so many rooms I walked into. I had the experience of co-locating in the NICU with families that were struggling with complex deliveries. So much of what Dr. Holman just shared, I saw firsthand that for so many, they were thrown into these situations and their experiences were not congruent with what the messaging was of the broader world. This should be the happiest time of your life. For so many, it wasn't, and that creates so much tension. I here at Nash, I started here last November. I love that our mantra here through COVID has been, it's okay to not be okay. I see that as such a strong and important message in this corner of mental health care, especially in perinatal care. I have the honor and privilege of meeting with women for individual therapy. I also run a therapeutic group that meets on Tuesdays that has a really beautiful peer element where I get out of the way and let women just talk with each other, give each other support and advice, and then try to insert a little bit of evidence-based practices, some therapeutic wisdom for coping skills. But I just see that this is one of the most important topics that is starting to kind of bubble up in the kind of cultural narrative, but I'm really excited to see the conversation happening here in Lawrence to elevate it. I also approach with a lot of humility just the other folks that are up here on this panel, knowing that a lot of work has already been done in Douglas County. There's some really brilliant and beautiful conversations already happening, so it's really exciting to get everyone into one room, start elevating that, kind of networking together, figuring out how we can take the next steps forward.
Hello, my name is Kay. I am a tattoo artist, if you can't tell. I'm kind of the oddball up here, but I wanted to speak on postpartum depression and all the things in between because it's not normalized what happens after birth. A lot of people think that once you have a child, everything is perfect and everything kind of revolves around your kid, which is true, but you matter as well. And I think that it's crucial to bring awareness to men and women on what birthing parents go through. And we need to know all of our resources and come together, especially as a community, so that we can be here for each other and understand what everyone's been going through after the entire process. And even when kids are, super young, like babies and infants, we need help. And it's really hard to ask for help because you just think that you should know it. You're a parent now, you should just have it together. But it is okay to not be okay and ask for help.
My name is Tracy Dotson. I am the program manager for doulas of Douglas County. We are a newer kind of program in the last year or so, started taking on new families. I am here because I think that representation is really important, and so recognizing that not just in perinatal mental health, but mental health in general, that there's a lot of stigma for Black and brown families and in the Black and brown community. And so for me, and our role as doulas or as doulas is to kind of break down some of that stigma, normalize some things, walk into spaces where Anna and Dr. Holman and Mel are working. And so that is why I am here.
Wonderful, thank you all so much. Well, I will kick us off with our first question and then we'll open it up for audience questions. So, Dr. Holman, you briefly touched on this when you just spoke, but in our country there are significant racial disparities in mortality rates in perinatal care. I personally have heard from several friends and community members that your trauma-informed care when it comes to people of color seeking out perinatal care is unmatched. Can you please tell us a little bit about your passion in addressing minority and perinatal mental health care and why you feel it is important to be discussed?
Oh, that's nice to hear. Because all I hear is when people are mad at me. So I think it starts with being a caregiver in general. I have a very long, weird history with just being white and navigating being white and seeing white as a culture. However, my husband is Black and I have a Black daughter. And so, wow, man, we're getting deep fast. So I think the first time, I think it was Ferguson, I was laying in bed crying, oh my gosh, I shouldn't have to worry about my daughter just because she's brown, this is awful. And then I felt like a real schmuck because I thought, oh my, I'm gonna cry. My mother-in-law has worried about my husband every single day of his life. And that was when that idea of white privilege really hit me. And I already knew before I went to medical school that I would be granted some social credibility whether I had earned it or not, and that I wanted to use that in a way that was useful. And so I'd always been interested in like violence issues against women and such, but that's when I got super into like reading every article I could find about the racial disparities in the United States. Black women do die 4 to 5 times more at higher rates than white women. And the part of it that I think is the most troubling is that as white women get more education, more stable housing, live in more affluent zip codes, etc., their maternal mortality goes down, and as Black women get those same things that we consider to be protective, they exponentially go up. So the last piece of this is racism. It's the system, right? So understanding that, I've done a lot of work with like implicit bias, and then a lot of work of like what bias patients may bring in as well. Like sterilizations against people of color, unconsented, and these things were happening as late as the 60s and 70s. I was born in the 70s. This could have been my mother. So I really looked a lot and tried to work with our team and our birthing center and my office a lot about sometimes the patient's not untrusting or non-compliant or difficult. Sometimes she's scared. Sometimes she's been hurt. Sometimes this doesn't feel like a safe space. And this is where Tracy's program comes in, right? And programs like Tracy's. And so that's kind of been the fuel for it. And so, of course, it expands in like medical and comorbidities and death and listening to people. And then that also spurred some of my passion with trauma. Of course, I've been interested in violence against women and sexual assault ever since medical school. But I think these, watching people that look like you be killed, watching these things. I mean, the history of our country is also a trauma. And so that's when I really started exploring that. I got a certification last year. and so I agree with Tracy, representation, and so if there's anyone that wants to correct me, I am open to criticism and correction, and you could have said this a different way, but I think representation, and so it's a lot of just working with staff. I'm constantly sending out great articles that I find or good information. Dr. Pasha comes every year to LMH for the last 3 or 4 years. He's out of, it's either Nebraska or Oklahoma, and I always get it wrong. And he comes and does trainings at LMH and in our community, and I encourage everyone to go, and I encourage really open, honest conversations. I've heard of little jokes being made on the unit that I'm like, oh, that's not funny. So like I will talk to our nursing staff at staff meetings, or I had a patient that specifically put in her birth plan that she did not want African American vernacular English used with her, and I realized a lot of people in the unit aren't going to know what that is. So I worked with Erica Hill, and we put together like a little education for our nurses on that and why it could be othering to people, and why we just need to be cognizant of these things. So I think I've gone off track, but I think with mental health especially, there's already a stigma with it. Postpartum depression was 1 in 6 women, but that was in 2019, so I mean, twice as high now. So this is so prevalent, and I can imagine that, as a person of color, it may be very hard to walk into these spaces that have been traditionally powerfully white, and to share and to be vulnerable, and so I just want to help. I mean, every little bit of energy, and we do have 2 Black nurses on our unit now, and I do a lot. Every year I teach obstetrical emergencies with our nurses, and so I've been including maternal mortality and the highest rates and what is killing women in America, and we've been discussing racial disparities. So I'm just trying to bring awareness, and so I've told our nurses, like, I'm not doing this for you. Anybody who wants to speak, I want to elevate and celebrate the voices that matter, but I have the energy, and I have the privilege, and I have the social credibility with my MD that I'm willing to be the person to go out on the line and speak and do that. So that's kind of my role at LMH. That's probably why I'm getting this little reputation.
Thank you. Do any of our other panelists have anything to add on that question?
Just a couple of things that come to mind. So prevalence-wise, statistics on perinatal mental health are a little varied, but by and large, 1 in 5 women will experience a perinatal wound complication. That goes up to twice as much for our Black and brown parenting people. So in addition to that, those people are less likely to seek help and receive the help that they need to be treated to remission, right? So identifying it is one thing, but then getting the care. So are there people that look like them in the community that they can seek that help from? Is it a safe space, that sort of thing? And just to talk about the maternal mortality, I touched on the couple of statewide initiatives that we have going on, and one of them is the MAVIS project, which stands for Maternal Anti-Violence Initiation and Sharing, or Intervention, Initiative and Sharing. I knew I was going to get that wrong. I just call it MAVIS for a reason. So MAVIS is the result of looking at our maternal mortality statistics in Kansas and recognizing that we're about twice the rate of the Healthy People 2020 goal. So we're above where we need to be. And, looking at cross-training our support people who are working with women who are survivors of interpersonal violence on perinatal mood and anxiety disorders, and then cross-training our perinatal providers on interpersonal violence and how to support these women, and in addition, including perinatal substance use in there. So just from a statewide initiative, we're lucky that Kansas is really looking at that as well.
Awesome. Thank you both so much. I have a ton more questions, but I'll give everybody else their turn, I guess. So how we'll do it is Carrie up here in the yellow. She will have you raise your hand when you have a question, and she'll bring the mic over to you so that you can ask the question. So if anybody in our audience has a question to get us started, feel free to raise your hand.
Okay, so I think most people think perinatal mental health as postpartum depression, but can you talk a little bit about what other kinds of mental health symptoms or diagnoses are seen with that? Okay.
So I'm so glad you brought that up. That's something that when I speak about this, I often start with. So you've heard us say already, perinatal mood and anxiety disorders is sort of this blanket term that encompasses all sorts of mental health complications that can occur in the perinatal period. And we should stop and just say, what does that mean? So pregnancy and the time period birth to 1 year of age, for the purposes that we're talking about. There are other definitions of postpartum, but perinatal for what we're talking about today is that. And it is very limiting to just say postpartum depression, right? Because as Dr. Holman said, this doesn't look one way, right? And so we know that there are people who come into pregnancy with a pre-existing mental health condition. There are people who develop that mental health condition in pregnancy, and there's people who develop that postpartum. So it breaks down, probably about 40% enter into pregnancy with a pre-existing mental health condition, and then about 30 and 40 for pregnancy and then postpartum. And so there are a range of things. We know that people can come into pregnancy with a recurrent major depression or a generalized anxiety disorder, a social phobia, panic disorder, post-traumatic stress disorder. This, Dr. Holman talked about birth trauma. There's also the pre-existing trauma that occurs before a person gets pregnant. And how does that look? How's that exacerbated in the perinatal time frame? Bipolar illness is a very, very common time for women to be diagnosed for the first time with a bipolar illness. So this may be somebody who has presented with depression before but never experienced hypomania or mania. That's a common time for that to occur, especially in the postpartum period. And then postpartum psychosis or psychosis is less common. It occurs in about 2 in 1,000 births, but that too is kind of one of the many things that can occur.
I guess just to add to, there's so much normative symptomology that can emerge during this time too. We talk about the baby blues. So there is a level of just kind of clinical precision to be able to talk with someone about what their experience is and parse out, is this something that is meeting that diagnostic threshold, or are you just anxious because you're going to be delivering in 3 weeks and of course you're anxious. So that is kind of just a challenging piece of this time period, is trying to separate out any normative symptomology that we might be seeing versus that clinical threshold where that intervention would definitely be key. Yeah, so just in kind of that delineation between postpartum depression and the baby blues. The baby blues we know is a very prevalent, highly common reaction that can happen kind of biologically, and there's still just the stress response to from the situation of having a baby all of a sudden. So your hormone levels go through the floor, right, when you deliver the placenta. So there's this big dysregulation in the body that's happening. And then there's suddenly this significant environmental stressor if you have a newborn baby to cope and contend with. So there's this normative range of the first couple of weeks, 2 weeks after delivery, where it's like 80% of women, I think now, where we see that normative range of, yeah, there's a big adjustment that's happening. You might be tearful, you might be having trouble regulating your sleep. But we cross into that threshold where of kind of looking more at major depression, where we might be out of that time period and still seeing some of those symptoms emerging, or just a more severe, intense level of that symptomology. If there are thoughts of harming yourself, harming the baby, you're not able to sleep even when the baby is sleeping. Some of these red flags that we're watching for to see if there's still this persistence or intensity of symptoms, that's when we would want to be talking with women about treatment options.
So outside of the postpartum depression lane, there is postpartum rage, there's postpartum anxiety, there are weird triggers that you're not expecting to sneak up on you, and it's just because of the extreme mood swings from having such hormones leave the body. And I think for me personally, body dysmorphia was a really big issue, because you have this thing growing inside of you and it's beautiful and you're beautiful, but then you feel like a beached whale and you can't move and it's hard to do certain things like tie your shoes, and then all of a sudden you give birth to a baby and you're back down, not necessarily to how you were before, but you get really big and you get really small, and then you start fluctuating for at least 12 months afterwards, sometimes longer, and it's totally normal, but we don't talk about it. And a lot of times I see a bunch of girls, I myself am included, I have posted pictures on Facebook and social media like, oh, look how good I look in my new mom bod, but there's a lot of layers to dissect there with self-esteem issues, and especially with postpartum rage. I mean, it's very quick. You can snap for no reason. I used to get really bad anxiety when I drove after I had a baby, and at first it was because I was scared to have my kid in the car. But then it was like random things like horns honking on the street, and I would get so angry and scared, and I would have to pull over. And I actually got on medication, which has helped me tremendously. I went through therapy with Anna, and I got on medication, and it has helped tremendously. But I did not know those resources were available, so I'm very glad that I finally admitted that I needed to seek help on that. So
I think that I wanted you to have a doula because it's that postpartum period and those first 2 weeks you're just sent home with this baby, and if it's your first baby, it's like, really, what am I doing? And I'm really in over my head. And there's not people checking on mom as much as they're checking on baby. Like, how's baby doing? And oh my gosh, send me the pictures and all of the things. And no one really stops to say, like, have you ate? Have you slept? Have you done these basic things that we as humans need? And just how that can, it's like, shoot through the roof any other issue you're already having. So our doulas, they're good about going in and insisting on mom rest, and even if it's, hold your baby, because sometimes it is, like, you just need time to hold your baby and all of the other things need to be handled, and I don't need to be the person to do that. And so doulas play a nice role in that. And then also normalizing the baby blues, but then recognizing when it's not normal. There are eyes that are in the home, and a lot of the time, or by the time that you have your doula in your home postpartum, you're comfortable, and they can see those things, and they know you're not your normal self. And I say normal self, we meet a lot of people during pregnancy, so you're already not that normal, typical self. But really being able to go through the pregnancy, labor, delivery process, and then be there postpartum, you can see some of those things. And so I really do value and want everyone to have that support postpartum, because that is the most important time. And so many moms end up by themselves, and I say moms, parents end up by themselves. And it's just not a good time to be alone. We shouldn't be parenting alone. That's not normal. And so we talk a lot about that.
There's one thing that I forgot to add, and it's going to get a little raw, but I am a survivor of sexual assault, and I was not expecting to be triggered as such after having birth. And unfortunately, there are a lot of people, a lot of women who have been victims of sexual assault, and we do not talk about it. And I'm here to talk about it. So I did not expect to have any kind of trigger when I had my son. And I remember she delivered my son, so I know her on a very personal level. Yeah. And she asked me, she said, do you have any, passive sexual assault? And I said, yes. She goes, well, you might have some difficulties being in the room, like when you have birth. And at first I was like, oh, okay. And I didn't really think too much about it, but afterwards, looking back, absolutely. I definitely had trauma. And I would say that, libido goes down. You don't have interest in anything in that area, revolving around that. And it makes you question a lot about yourself. Is something wrong with me? Do I need to be doing something? Like, am I worthy of being loved and having attention and all that? But I think the actual trauma of my birthing my son, there was something physically that was triggered. And I still don't know exactly what it is, but I know that it was triggered. And especially with how many people are victims of sexual assault, we really need to be there for each other and talk about this and normalize what to do if we get to that trigger. So.
Thank you all. Does anybody else in our audience have a question?
I can take a shot if that's all right. This one's actually for Tracy. So, pretty unfamiliar with doulas and what you do. So could you kind of talk about that and where you fit in kind of all the services that birthing parents get from finding out they're pregnant to after delivery and everything?
Yeah, so I always walk into conversations and forget doula is not a normal term that everybody hears. And so I think one of the easiest ways to explain it is that we are non-medical birth support. So we really focus on the physical, emotional, informational support side of things, preparing you for labor and delivery, and those things that we're talking about, like no one told me this was gonna happen. That's where the doula comes in. We try to do a lot of it during pregnancy, and so I always tell people, as soon as you're finding out you're pregnant, get connected. Your doula is someone who can help you identify providers even, like where do I go now that I know? And so we handle like those kinds of things that support during labor and delivery. So if you're someone, I mean, everyone deserves that support for labor and delivery, but as Kay was speaking to, just the process of, what your body's gonna go through and identifying if it's gonna be something that's triggering for you. And so we're another person to have that conversation with and early. And then postpartum, what the doula looks like really varies depending on the family and what they need. So sometimes it's just not being alone, and so partner goes back to work or mom is a single mom, and so the doula can go and spend a few hours providing that relief, especially in those early days, first few weeks postpartum. They continue to have visits, and it may be connecting to additional resources. So if we're noticing after the first few weeks mom's having a hard time adjusting, we might start making referrals for additional parenting support, for mental health support. So a lot of the time there's just like a financial aspect too, so identifying some of those resources. So doulas are all encompassing in that sense. And then we also handle some of the things that we don't like to talk about, like if there's a mom or a person who finds out they're pregnant and they don't know what their next move is as far as parenting, adoption, or their options. We have those conversations. We handle loss, and so that's another thing. If you're on your second, third pregnancy and you've dealt with a lot of loss and how there's certain stages of pregnancy that can be triggering. And so navigating some of those things, knowing when to pass it off to, professionals, because doulas do a lot of peer support. And so I hope that answers your question.
Thank you.
Thank you. I'll go ahead and ask a question while other people are thinking about it. This question is for Anna, but everybody, please feel free to jump in. So, while this topic is usually centered on the birthing parent, can you speak about the impact the perinatal journey can have on the partner or spouse of the birthing parent?
It's a really important question and sometimes gets missed in this conversation. I might lean on Mel for the stats because I'm a terrible statistician, but postnatal depression is absolutely a prevalent concern for birthing partners. I'm not sure if it's like 1 in 8. I'm sorry to put you on the spot, Mel. You shouldn't have to know every.
And most research being in maternal, knowing we need to expand that more, but
Yeah.
1 in 8, 1 in 10.
So 1 in 8, 1 in 10. And like many mental health statistics, we suspect that that's largely undermeasured. We don't have a lot of research in this area. We don't have enough research even for birthing people, not to mention the partners of people, and not to mention all of the other intersections of who the birthing partner is. Is this like a cisgender heteronormative couple? That's not always the picture. So there's very, very different statistics and prevalence when we start talking about medical discrimination, what partners are and are not made to feel welcome during the OB visits and labor. So there's layers to this, like there are intersectional layers in all of our mental health care concerns. It makes a lot of sense though when we think about it. Of course, this is going to put pressure on both of the folks that are welcoming an infant into the home. There's equal feelings, I think, of just this isn't matching up with the reality that I had expected. There can be a lot of felt helplessness of I don't know how to help my partner. I see that they're struggling. That's a really uncomfortable and hard position to be in. So I think in some, this is a really understudied but widely known, if you're in this community, that it is a very impactful corner of mental health in the perinatal time.
Thank you. Does anybody in our audience have a question? I think the mic's working, so Carrie can bring it over.
Okay. I just wondered, certainly I've seen people have, young women with breastfeeding have some real issues, and especially, and it seems like have we not done better? It seems like they're all in shock that it's not more enjoyable, and that they were all told it was going to be just heavenly breastfeeding their baby, and it's not, and that seems like a real kid. So are we doing better with that, or, you know, what do you think?
Here, I'll take it away. So I have a son, he's 15 months old. I attempted to breastfeed as long as I could, and I remember I had such a plan. Oh, I was gonna breastfeed for a year, and he was gonna be beautiful, and it was gonna be glorious, we were gonna connect. No, that lasted maybe 3 months, and I had to use formula as well, and I felt defeated. And I actually went to my OB and asked her advice on it because I had no one else to turn to really. And she showed me a video about basically like how formula is okay, breast milk is okay, like it's okay as long as your kid is getting fed. And that's truly what the root of it is. And I have so many women that I'm friends with, and they breastfeed their kids and they're like, oh, it's so easy. You know, I breastfed for 2 years, and it just depends on how your body is. Sometimes you just can't produce milk, and there's nothing, you know, defeminizing about it. It's just what it is. So.
So, no, we haven't done a good job of saying this can be hard. And in fact, if anything, I think social media, etc., we've gone way too far in the wrong direction. When my daughter was a 35-year-old gynecologist, one of my very best friends is a midwife that I used to work at a practice in Junction City before I came out here. And she successfully breastfed her son that's 4 months older than my daughter with one breast because she had a mastectomy for cancer. And I was like, that's so cool. I can't wait to do that. Like, oh my God, it's always the right temperature and it's right there, right? So I'm like, oh, I can't wait for that. And that was not my experience. Like, I had so much difficulty, and I was a terrible producer, and my nipples hurt, and I had to do this tube feeding of the breast, and I was waking up every 1.5 hours for 21 days. I was a mess. But what do we have, right? Okay, and I know this is being recorded, but over at LMH, we're a baby-friendly hospital. When I heard we were doing that, I was really pissed. There is data, it's a Healthy People 2020 goal, right, to have so many hospitals, a baby-friendly hospital. So I said, well, where's the data that these parents that go through this super intensive 24, 48, 72 hours have better breastfeeding rates in 6 months or 12 months? There is none. Everything on the baby-friendly website is how many hospitals are baby-friendly, and it's a proprietary program. It's very expensive. So, I don't like the program. And I think when we look at the medical community, what Tracy was saying about how's the baby, how big's the baby? We don't even weigh him for the first hour. And these parents will get 17 texts about how much does the baby weigh, right? It's all about the baby. Even for JCO, so for our Joint Commission or Medicare, why is Medicare even involved in pregnancy? So even like our Medicare, PCO1, PCO2, all of them are baby, except for one is maternal. And you know what that is? To reduce the number of C-sections. So it's not even a maternal care, it's more like a statistic. And so, you know, I'm also on the primary C-section committee, and we have a month that's an outlier. We review every case and make sure we gave that parents every opportunity for vaginal delivery, and make sure they returned, and make sure we waited long enough with the Pitocin, and you know, so, but that's it. That's all we care about is like that statistic. These shirts, I said years ago, I want them to say LMH loves families, not LMH loves babies, right? Because we love the moms and the dads and the godmothers, the grandmothers, the aunts, the uncles, we love anyone who's gonna come and love on this couplet. So I think, not only have we not done a good job of educating, we've gone and made it this blissful thing that defines you as a parent and a mother and a woman. And I think we've definitely gone the wrong way. I also say I'm embarrassed of this, but as an OBGYN who finished residency, I had gotten 3 hours total on breastfeeding. So we do have lactation consultants, and there is a role for that. So I did a bunch of training on my own after I had my daughter, didn't have any more kids, but at least I'm much better at counseling and helping women. And I think from a mental health standpoint where it turns in, rather than, I think that the Baby Friendly Initiative has made parents feel guilty by asking for formula, have made them feel guilty by asking for the baby to go in the nursery. And I complained about this to a former director, and she said, well, because I said, if this person was in labor for 36 hours and on magnesium for severe preeclampsia, and they are exhausted, and they had a major abdominal surgery at 4 o'clock in the morning, this is not someone who should be taking care of a brand new infant. And they told me, and this is not our current director, but they told me, well, they're not gonna learn the baby's cues if the baby's not in a room with them. I'm like, they're not gonna learn anything right now. Like, they've been awake for 36 hours on magnesium, which if anyone's ever had it, it makes you hot, tired, feel very drunk. I mean, it's not a kind medication. Prevents seizures, saves lives, right? So we're gonna go ahead and use it. But it's not a kind medication. There is no reason to not take that baby to the nursery and give those parents some respite. So I think not only have we not done a good job, we've gone the wrong way. And now we've made parents feel very guilty, inadequate. Oh, and the baby friendly. Never in the curriculum does it mention some women cannot breastfeed due to social factors, if they are being abused, if they leave the hospital and go into a shelter or a community living situation. Those women should not ever feel forced to breastfeed. And some of them can't, like I said, because there's an abuse situation, and it doesn't even address that. Right, that just doesn't exist.
Just talking about breastfeeding, I think a couple of things come to my mind, if that's okay. Just the bilateral relationship, right, between mental health and the breastfeeding experience. So there could be the breastfeeding experience that is more challenging, not going according to plan, and contributes to the mental health. Also, our mental health condition can contribute to our ability to breastfeed successfully, to have a sufficient milk supply, and so forth. There is a lot of misconception out there about, I'll speak from the psychiatric standpoint of using psychiatric medications while in breastfeeding, same thing with pregnancy, but by and large, the rule would be that it's gonna be okay. It's rare that it's not, right? But that doesn't mean that a woman should feel like she has to, right? Because there are many other factors that go into deciding whether the breastfeeding experience is gonna be right for that woman. And so I find when I'm fortunate enough to work with women in pregnancy leading up to delivery, that's a lot of our conversation. What would that breastfeeding experience look like for you? Not just, is the medication you're taking compatible with that, but what is that going to look like for you? How are we going to prioritize sleep? How are we going to support you in that process? Who's going to be there to ask questions when you have them? It's not a very simple answer, right? And for a lot of people, it does take then, how do you then advocate for your choice, right? How do you feel good about that yourself, and then how do you communicate that to the rest of the care team? So that's a big part of what I do.
So I think that with the doulas are attempting, and that's something that they do, is sharing some of the woes of breastfeeding too, without completely scaring people out of it. But I think, like you said, with the Baby Friendly Initiative, really a lot of the time we're looking at statistics like how many people started breastfeeding. No one cares how long breastfeeding lasts. So you started it, that's great, and we put you through this process of your milk coming in and all of these things. And then 2 weeks later, it doesn't fit your lifestyle. And that's something that we could have identified so early for the the person who maybe has to go back to work a lot sooner than what we think of as normal. I think everybody typically thinks like, oh, you get 6 to 8 weeks off when you have a baby. Not everybody gets 6 to 8 weeks off, and a lot of people that do don't get it paid. So then we have to start kind of balancing things and looking at, pros and cons and what's healthy for the family. And we always say, like Kate said, feeding your baby is what's best. And so we're not ever like have this ulterior motive of like making every mom breastfeed. That is totally within their choice, and we want to provide the support when they do choose to. And then recognize, again, where mental health and breastfeeding can maybe fight each other. And then another time of transitioning with weaning, and that is a loss for moms, and we don't talk about that part of it. Or with my baby just self-weans and stops latching, and what's wrong with me and my milk and all the things. So it just really does start down this rabbit hole, and so it's always about having someone there, having eyes on the family, and so I think that's why it's so important that we all are working together as service providers to ensure families are wrapped in that support, especially postpartum and during pregnancy.
Well, Tracy, while you have the mic, doulas can be a critical part of the team, supporting the needs of the birthing person and helping to ring the alarm when there is potential mental health issue arising. How do doulas help a client navigate perinatal and postpartum mental health?
So I think I've talked a little bit about it, just at different points, but normalizing a lot of things, talking about baby blues before they happen, while you're pregnant, what to expect, and then making a plan during pregnancy for postpartum care. That's bizarre. We talk about birth plans a lot, but let's talk about postpartum care plans, and who's going to be home with you and baby, and if you need a shower or some relief and those kinds of things. So I think those are kind of the first things. There's like preparation, prevention, like let's get ahead of it before it's an issue, and then recognizing when it is becoming an issue. The doulas do spend quite a bit of time with their families. Each of their visits are anywhere from an hour to 3 hours, and you can really talk about a lot and really get to know a person a lot, especially during pregnancy. And pregnant people a lot of them love talking about the pregnancy, and so we give them that time. And by giving that time, you can see, or a lot of the time, just spending time with families, you will see some of those red flags or areas that could potentially be of concern, risk factors, things like that. I think that answers the question.
Do you have any audience questions? Or jump to another? Okay. Dr. Holman and Melissa, are there screening tools in place for birthing parents? If so, can you share what they are?
So there are, do you want to talk about, the only one I know is Edinburgh, because that's the one we use. Okay. So there are screening tools that can be used. There's, I think, 4 or 5 that are validated that we use. The most common probably is called the Edinburgh, and so I actually looked this up last night to make sure I didn't misspeak. So the American College of OBGYNs recommends a full mental health assessment at some point during the antepartum period, while you're pregnant, and at some time within the first 12 weeks of the postpartum period. We actually do it during the birth stay too, which I think can be a little sketchy because it's like in the last 7 days have you, and it's like, well, again, she was up for 2 nights, her butt, her breast hurt, so that one's probably not quite as helpful. But we also work with the pediatric offices, so like when the parents take the infants to the peds appointment, they will actually administer to the parents as well, and they'll call us if they're concerned. So yeah, there's definitely screening tools, and I think another tool that is equally as important, if you look at like the risk factors for peripartum mood disorders and depression, anxiety disorders especially, what are some of the risk factors? Unstable housing, food instability, socioeconomic, all these socioeconomic factors. So we also, at our first visit in our office, our nurses go through a social determinants of health with the patients too, to try to early on identify substance use disorders, psychiatric disorders, housing and food instability and things like that, and hopefully, get people plugged into services early on. So that's another screening. So it's not necessarily a mental health screening, but certainly people who have these other factors are at increased risk of having psychiatric and mental health disorders as well.
So the Edinburgh, or EPDS, is what you often hear called, is the standard, if you will, because it really is tailored towards the perinatal population, as compared to something what's called a PHQ-9. So I know some people in the room are familiar, that looks at depression symptoms, but includes things like how are you sleeping and what's your appetite like, and we know that the normal physiological changes of pregnancy and postpartum can alter those things. So the Edinburgh is a little bit more geared towards this population, so it is a validated tool. The key really, the message is universal screening, right? That we want everybody to be screened because you can't tell by looking, right? So we're normalizing this by saying, hey, 1 in 5 women will experience something, and so that's why it's important for us to talk about your mental health as well as your physical health. And we're going to use this tool as a way to open up the conversation. And you may not identify with these things, but you might find there's something else that's bothering you, like I feel rageful, or I feel, so in addition to using the validated screening tool, it's about how we present it, how we set it up, how we open up the conversation for that. And one of the problems as providers is that there is really no standardized recommendation as far as what we should be using to screen, how often we should be doing it. So Postpartum Support International kind of has this gold standard, if you will, of screening every trimester, postpartum, and then at the 2, 4, 6, 9 month well visits. And that really then ties in like why it really takes a community, right? So we partner with our pediatric and family practice providers to capture moms and dads and parenting people who are at those well child visits, because we know a lot of times people are more likely to follow up with that care than they are their own care. And that's part of why we opted at LMH to do the inpatient screening, is that it may not be the ideal time to complete that screening tool, because it does ask how are you feeling in the last 7 days, and right, leading up to labor, being in labor. But it is an opportunity to capture people and ask, how are you doing? And it just gives us a measurement.
And this is something Mel and I have worked on a lot, like postpartum. Like Robin asked, is there a screening tool, right? So it's important to keep in mind that these are screening tools, because sometimes if the person administering the tool isn't pretty clear on that, then they think it's diagnostic. Oh, you're 16, you need meds. Oh, you're 14, you need this. But it's a conversation tool, right? Like, hey, you're at this level. How do you feel? Do you feel like you're at baseline? What is bothering you the most? And then you can get into what's normal blues, what's pervasive, what's really bothering this person, and giving them the chance to open up. I had a gal one time, she was screened at peds, and she screened really high. And so they called us, and there's peds was like, she has to be seen today. And we're like, okay, I had my nurse who knew her, could you give her a call? And she goes, yeah, I took this quiz at peds and I failed it. So I think it's also important that we keep in mind what that tool is, and truly what it is it's a conversation tool. Even people that are 0, I go, wow, your score is 0. Are you feeling really well? How are you sleeping? And even make sure she's really 0. Here she is. My patients are usually women, and I have not had any trans women deliver recently. Yeah, but yeah, we should do more with them.
And the Edinburgh is validated for use in men. Again, we need more research in transgender community and people who identify differently. But for men, it can be used, but the scale goes down, or the criteria goes down a couple, because there's one question that in validating this they didn't think really applied to men, which I'm going to disagree about, because it asks about crying. Men can cry, right? But in this study, that's what they recommend. So you would just decrease your scoring criteria, but it is validated for use in men.
Do we know, is it validated in transgender?
No, it is not. The other important thing about the Edinburgh is it's free, right? So this is a tool that is widely available online. It's available in a multitude of languages. And you don't have to be a medical provider. So this could be some, we have our, I don't know, Tracy, are you guys screening? Yes. Woohoo, they're screening, yeah, that's awesome. Yeah, so our home visitors, our doulas, our parents as teachers, educators, as well as medical personnel can use this, again, as a tool to start the conversation. So it's not diagnostic, it just merely says, hey, you might have a symptom that's associated with these things. And we are talking to you.
So I'll just follow up on that screening question. So after these parents are screened, as we know, sometimes then they are not met with the care that they need. They are screening high. So in all of your opinions, what are the best ways that we can reduce the stigma of getting mental health care and increase access to mental health care? Sorry.
No, loaded, because I think earlier I mentioned that, identification is just one small piece of this, right? And so then it's the what next? And so oftentimes our providers may not feel that they have the tools to know what's next. Our community might not have the services to know what's next. They might be full or have wait lists, right? So, in addition to providing education for our providers, we need to do better just in general about services. I'm going to pass the mic, but I just want to put a plug in that this is where my passion for peer support lies, because peer support is something that is usually more readily accessible. It is validating. It is a type of care that provides a much different support than sometimes psychiatric care or therapy care can. So maybe we'll have time in a minute, but I'd like to share some of the peer support resources that are readily available to anybody that you encounter.
So you asked both about awareness and access, correct? Okay. So I think awareness, decreasing the stigma, is just just having that conversation all the time, every day. Like I said, even if the score is really low, I'm like, man, one, that's awesome, and sometimes I'll say, what do you think is contributing to that? You've adjusted, it looks like you're adjusting so well. So I think, addressing it, I share my own experience a lot, and I was sharing it so much in the room that I made a Facebook video, for our page. The first couple Facebook videos we ever put on our page was me talking about my postpartum craziness, and not craziness, but just anxiety and how tough it was. And I was a 35-year-old gynecologist, so I thought I was cool. Breastfeeding, enjoying the first pregnancy. So my first couple of videos were just kind of personal things that I share in the rooms a lot. So I think, normalizing it, talking about it to patients that seem to be doing well and not as well, right? Because it's just a standard part of our care. And then I think the last thing is, meds for access, right? For that access piece. People are pregnant and postpartum I find to be really resistant to medication. The American College of OB/GYNs has a really great practice bulletin on risks of medication versus risks of untreated mental health disorders. And I kind of share some of that with patients. So you've got to have a healthy vessel to have a healthy baby. And then some exploration of maybe why that patient is so resistant. I not too long ago had a patient that had only tried medications once, probably 4 or 5 years ago with a primary care, not in this community, that gave her 3 meds at the same time. So she took them all, felt way out, not herself, freaked out, and would never try meds again, but was smoking marijuana. And so, I'm really gonna get myself fired. Well, I have no problem with marijuana. It's not legal in Kansas, right? And it can have adverse effects. And we don't know what it can be laced with or what can be in it, especially because it's not legal and it's not regulated in this state. So I kind of said to her, I would, if we get to a point you can trust me enough, I would love if you would let me start you on something that I know, the side effects and the effects of pregnancy, rather than you getting something from off the street illegally. and she did eventually, and it wasn't that appointment, but eventually she did. So I think that too, I think there is, because there's stigma and because some medications do have side effects and because people misuse them and, you know, there's this idea like, oh, one med doesn't work, they just keep going up until you're a zombie and then, you know, just, you know, so I think breaking that down and just meeting them where they are and really talking about the safety profiles too.
I think one thing that really stands out to me in terms of identifying folks that might benefit from help, starting that conversation. This is community work. This is something that we all can do. We can all have more intentional conversations with each other, giving more permissiveness for people to be vulnerable, to say that they're not doing well. It's all in how we frame the questions. There's a really great mental health first aid training that's offered here at Burt Nash. I highly recommend that. It's a great tool to access how to kind of be what you should be watching for, how to approach those uncomfortable conversations, and how to feel like you have a little bit more competence of what to do next, because there can be that oh crap moment when you step into it, that how do I help next? So I think part of it is just acknowledging this is work for all of us. I will say that I see on the clinical side that there is an opportunity for us to have more concerted, focused training in this area. I keep seeing this really interesting thing as I've stepped into this work, that a lot of folks say, you know, well, I haven't had a kid, so I can't do that work. And there's just this level of discomfort of stepping into that. It seems highly specialized. You know, I've never lived with psychosis, but I've been trained to work with folks that experience that. I think that there are opportunities for our clinicians in the mental health field to step into this work, be a part of this work. It doesn't have to be specialized, it doesn't have to be niche. I mean, you should have special training, not to discount that, but that this is work for all of us as a community, as providers. The same is true for medications. I'm not a doctor, but my observation has been that a lot of medical providers feel very uncomfortable prescribing medications in pregnancy. There are really great opportunities for training to build competence in that area. Pregnancy is like one of the most common medical conditions for birthing persons. So it just makes sense that there could be an expansion of competency. There's an emerging conversation in this area. Trainings are available. There are opportunities to increase your competence both as a clinician and certainly just as people, as neighbors. So I see a lot of opportunity in how we can facilitate some of that peer piece that Mel mentioned. Maybe you have had experiences. There's an opportunity to check in with someone, share your story, see if that opens up the conversation differently if the person didn't feel safe to kind of share their full impact.
Okay. So something that was mentioned briefly, I think between all of us inadvertently, was that I think that it would be really important for men to also be asked, are you okay? Hey Dad, how are you? How are you taking this all in? How are you doing? You know, and I think that men should have just as much a say as women do in this entire experience, because at the end of the day, I'm in a hetero relationship, so I go home to my man and I ask him, how are you doing? And if he's had a stressful day, that reflects back onto me, that reflects back onto my parenting. So if he's, you know, if he's under pressure, if he's depressed, if he needs to seek therapy, if he needs help, if he needs counseling, men always kind of, at least in my upbringing, they're tough. You know, like you're not supposed to cry if you're a guy. It's demasculating, or like that question that you had mentioned, it didn't apply to men, like if they cry or something.
Right.
That's crazy. Like, of course they do. They're humans. Like, you know, and it's okay to cry. It's okay to show vulnerability. And men have a lot of their different pressure that's on them. And so for them to know that it's okay to relieve some of that pressure and to talk to someone about their mental health issues, to take some of that pressure off of mom and baby at home as well, or the entire family, instead of just harboring those things in and, you know, not getting medical attention, or at least talking to someone about it. So I just wanted to definitely let that know that that's important.
So I think that the awareness piece can happen with the peer support piece a lot of the time. So the doulas, many of them are mothers themselves. Some of them will be open and share their own experiences with mental health and struggling, postpartum, during their pregnancy, different things like that. And so I think when we talk about access and when there's long wait lists and maybe when the space isn't comfortable, that the doulas can be that space that is comfortable. They're coming to you in your home already, and those conversations are naturally kind of occurring. But then they can be literally hold your hand, walk with you into those spaces where maybe I don't feel comfortable because I'm the only person that looks like me. And so now I'm walking in with my doula, and even if that just gives me the brush of confidence that I need to advocate for myself and let someone know what's going on with me, or that I just need them to do that for me. So my doula goes with me and they share, like, this is what's going on. And that's okay, that we can be that bridge for families and for parents, whether it's mom, dad, whoever, to access the care that they need.
So I wanted to piggyback real quick, huh?
If we have time, we can talk more about maternal mental health or partner mental health, what it looks like.
Yes, and I often send people to Build Your Village, and it's kind of been nice that it's been on Zoom, because I think then you don't have to walk into the space. You can, hide your camera, put a duck up and just listen. And oftentimes it's just reaffirming to hear that other people have the same fears, feelings, and thoughts that you do. So I use that a lot. And so I kind of went straight to meds, but there are definitely other access. I send people to therapy. We have, our social workers can print off a list of therapists that accept a patient's insurance. And so we do multimodal. And I have just a care plan too that's like, it's kind of a promise to themselves for patients, especially if people were like, well, I feel like I'm getting over it. And it's like, I will shower once a day. I will get in sunshine and they can fill it in 5 minutes a day, 10 minutes a day. I will listen to music. And that I do encourage partners to do for each other. But I was also, last night when I was laying in bed, thinking about all this, and I thought, gosh, if I as a healthcare professional had an ask to the community, what would it be, right? And so this is what it'd be. I'm assuming everyone here is interested in mental health, or you wouldn't have taken time out of your evening to be here. If you have a patient who is newly pregnant or is considering pregnancy, right? So say you're doing therapy with them, they're considering it, please have them come in and do a preconception counseling appointment with us so that we can review medications that they may be on. And I am careful, I don't say, well, we'll put you on something safe in pregnancy, okay? Nothing's 100% safe, but there are really very, very few medications that are truly gonna cause birth defects, and so we have some concerns with, say, stimulants, and those are actually the meds that patients don't wanna get off of. And so what I say is, like, let's look at your list and let's get you on something that is the most compatible with pregnancy that still works for you. So I use the word compatible, and then I would also say, so like pregnancy is not as fragile as sometimes we think in the community. That baby's really protected, and most meds don't cross the placental barrier. So I would say encouraging your consumers and clients and patients to come in and speak with us if they share that they're considering a pregnancy, or letting, and do not tell them to stop all their meds when they become pregnant. I cannot tell you how many patients I have, they come in their first appointment and they said, well, I told my therapist I was pregnant, and they call their therapist, right? Because they're feeling crazy, they're tired, they're not sleeping, they're puking, and the therapist is that lifeline that helps them through it, and then the therapist goes, oh my God, stop all your meds. And then they come into me and they are crisis mode, or they're sobbing, or they've lost 15 pounds, or whatever, because their depression, anxiety, bipolar disorder isn't being treated. So those would be my asks, like encourage people to come talk to us early on if they're considering pregnancy and they're taking any meds, and then please do not have them stop in cold turkey. And if you're concerned, give our office a call. We invite, I always tell my patients, I love anyone who's gonna love on you. So if it's your pediatrician, if it's your doula, if it's your therapist, if it's, you have a psych provider that's in Manhattan, Kansas, okay, I'll talk to anybody. Anybody you give me permission to.
I know there's questions, so I'll stop the paternal talk for a minute and do that. Let everybody ask their questions.
It's more of a comment than a question. We were talking about awareness. That's okay. I think part of helping with the awareness is out in the community. When the other day, I heard his name was in Walmart, and a mother had, I think he was a 2-year-old child, and he was out just screaming. You could tell she was very flustered, she was embarrassed, she's like, oh, I'm so sorry, I'm so sorry. So, I just went up to her in a non-confrontative way, and I just said, hey, it's okay, you know, we've all been there, it looks like you guys are having a hard day. And then the lady behind me, she, you know, chimed in and said, yeah, you know, I remember going through that too. And I think just kind of stepping out of our comfort zones a little bit, and just, you know, offering that hand, because I remember when my kids were little, you know, being in the stores and just like being mortified, you know, that my kid's screaming, but like to normalize it, you know, that's, I mean, it's I don't know if it has to do with depression, but just parenting in general, because, I mean, it goes, you know, just praying my eyes open.
That's beautiful. The more we talk about it, right, I can't tell you how many people who have come to Build Your Village because somebody who's been in the group before met them at a park, or, you know, saw somebody in line at a Starbucks and said, hey, I see you have a baby, how are things going? And then, oh, guess what, they talk about it, and then, did you know there's this group? So I love that, that's beautiful. Were there any more questions, or should I just thought about some statistics or facts about.
Go ahead and talk about it while Carrie comes back, and then I'll ask my question.
Oh, okay. I just wanted to talk, again, we, most of the research is in people who identify as cisgender males, who are fathers, who are in that perinatal time frame. So we do know that when one partner is suffering, it's about 50% more likely that the other partner will also develop a mood complication. So you have partners who need to, how do I support my person, right? And I'm holding it together. And then it's most common to see, like in the 3 to 6 month range, something start to develop in the other partner. When we are talking about, again, male, typical paternal presentation, we joke, you know, about the crying piece, but typically a presentation would look a lot like anger, withdrawing from their obligations, or isolating themselves from others, busying themselves with other things like staying later at work, or maybe, you know, engaging in video games all night instead of interacting with the family. And so the presentation does look different. I know I'm talking to a lot of people that know that, but I think it's just good for us to know as community members too, anger, withdrawing, you know, these things can be symptoms of depression as well.
Absolutely. Carrie's bringing it to mind.
My question goes back to what we spoke about before, which was when you were talking about normalcy and seeing anxiety within a person as a doula or as a person as a peer support. If a person is at a point and you notice these things and you're resistant to you guiding them to the help they need, what is the process and what is the success that you experience? Anybody?
So as the program manager, I'm not always the person serving them directly, so I usually hear about the resistance after the fact, like I tried and all the things, and now what? Like I'm going back to the visit, what do I? So I think that that's the beauty of it too. We get to go back and see that family. So maybe we introduce it the first time and they're like absolutely off the table. I'm not hearing it. I'm not open to that kind of conversation. And then maybe it's that you hear it again from your partner, and so it's like, hey, okay, maybe there's some truth to this. Like my partner's saying I'm on edge and all the things, and now my doula's seen and said and brought it up again. And so I think they do a little bit of self-reflecting at those times. But we also have to meet people where they're at is the other side of that too. And that sometimes they're just not at that point. The other side of this is recognizing how long these issues can go on. And so sometimes it's maybe not right now, but we do 6 months down the road, it becomes a crisis and you need help at that point. And so, I mean, I hate that it gets to that for people, but sometimes it's just being in crisis mode. So like, and I think that's another reason that it's nice that the doulas get to stay. So if we can see at 2 months postpartum that the parent is really struggling and they have not been receptive to receiving additional support or accessing that other support, we're not going to leave them. So where we typically say we do visits for up to 12 weeks, that family might get more visits. And a lot of the time they want more visits, and that's the one that clings on to you. It's like, no, I don't want my doula to stop coming. And we're like, okay, so let's talk about the scope of a doula and what we usually do. And if you are benefiting from and feel good about having these conversations with me and continuing these meetings, how do we find someone else that can be that support too? But that's also another unique thing about our program is that we really hope that our families stay connected, whether or not they are continuing to have regular visits, that they know that they can come back, that we'll have support groups, just different opportunities for them to stay engaged, and that those are hopefully moments where we can continue to plant those seeds. And I always tell my doulas, I'm like, we're planting seeds, you're not always gonna see the flowers, and that's okay. And it's really hard to do because they love their jobs, they love these parents, love the babies, and want to see everybody get that support. So, I mean, I think biggest thing is we're adamant about it. We don't let up. It's a lot of I see you, and that's valid, and you deserve this help, and reminding people that the help's there and that they deserve it to access it is another piece of what we do. So,
I just wanted to add to that real quick. If you know somebody who is reluctant to want to hear help, then I suggest getting them in their comfort zone, finding something that they enjoy to let them know that they're not being cornered, they're not being attacked, and then gently introduce the topic, like, hey, so how are things? And, they're gonna spew it out, at least a little bit of it, and then gently kind of talk about, oh, well, I was in something that helped me with this, and don't make it about you, but gently tell them, hey, I've been there. And it's okay, like this is what helped me. So me with my job, I'm a tattoo artist and I'm basically a therapist. People are very vulnerable with me. They're half naked, getting stabbed for hours and they can't move. So they kind of have this need to spill their entire life story to me. And I just listen. And I think that at least with what I do, it is amazing to see how vulnerable people will let themselves be. And they get out a lot more than just a tattoo at the end of our sessions. They leave with information and resources because I will relate myself to them. And don't corner them, I don't attack them, I don't say, oh, you're doing this wrong. It's more of like, oh, this might make your life a little easier, you should try it out.
So I want to just real quick, this is also why the Medicaid expansion in Kansas was so important, because like Tracy was saying, you can plant the seed, you can offer help, but if they lose their insurance 8 weeks after this baby is born, right, we're having issues with getting access to contraception, which some of these devices are incredibly expensive, getting access to mental health care if they, if they're in a crisis mode 4 months down the road, 5 months down the road. And then we didn't touch much on substance use disorder, but a lot of our increase in maternal mortality is drug use. So people get off of opiates particularly, when they're pregnant, they're very motivated and they get on a maintenance medication and then they lose their insurance. And now they can't get that maintenance medication, and then they return to opiate use at doses that they used prior to getting on maintenance, and they overdose. So if you put together the suicide, pregnancy-associated suicide, pregnancy-associated homicide, and substance use deaths, that is 20% of all of our maternal deaths.
I just actually wanted to circle back to something Dr. Holman said earlier, which is sometimes folks don't follow up, and it's not always that it's just non-compliance. I think it's really important to get curious about the barriers. So we talked about this before. I'm wondering what's standing in the way if you go into an appointment. It may actually not be that they have no interest in that service. Maybe they don't have a ride. Maybe they had a really bad experience with a therapist one time and they need someone to validate the possibility that there could be a different therapist that would be a better fit for them. So I think it's always important as we are meeting people where they are, validating that ambivalence. Okay, that makes sense. I see why you haven't taken that step. Exploring kind of like we always are really into motivational interviewing in the therapy community. kind of amplifying that change talk. If they are giving you an inch somewhere, like, oh, I've heard you say that before, that it sounds like that's still on your mind. Figuring out the barriers, trying to kind of see if there are any ways around them, ways to resource them or kind of talk through them. But just to never take it to sit face value that I plugged this once and they didn't go, so they must not want it. Usually there's a bigger picture, there's a bigger story there.
Yeah, I think that Kay spoke to it, like, you know, you're a self-certified therapist, and there are many of those, especially in the Black and Brown community. A lot of the time with our moms, you'll hear it's their person that does their hair, it's the person that does their nails. For dads, it's the barber shop and that time with the other men and having that talk. And I think we have to accept that, and that is some level of help. It's self-help, it's peer support. It might not look like what we as service providers are traditionally used to, but it is something, and it is a starting place. And so I think that, again, those are places where I'm like, we need to be building connection and community and giving those people the resources. So, like Kay, from her own personal experience, has all of this support that she can offer to whomever is coming and sitting, and it's probably not the pregnant person, but it is postpartum, and, you know, the first, you know, we want babies' names and footprints and all those things. So I do believe that you totally can experience this, and so recognizing that it takes a village, that this is something that all of our community is responsible for, and that caring for babies means caring for mothers, and that is what we're trying to do here.
Thank you. I think we have time for one more question. Karen.
Well, I think most of us understand how everybody gets paid except doulas. So what is your funding source?
Yes, so doulas are so underpaid, but we'll never be able to pay them enough. Our collective, so we're in year 2 of serving families. We had startup funds that we received from a preschool development grant with the Kansas Children's Cabinet. And so that has sustained us through now and into early next year. And then we just received a really significant sponsorship that I can't talk a lot about, but there will be a press release coming. And that is sustaining us to serve a significant amount of mothers and our birthing people in our community, and even filling a community closet so that we will have wellness supplies for birth, postpartum, babies, moms, support people. So it's, yeah, we are constantly looking for funding. It's a lot of private support, so we're always taking donations. I will plug that there. I mean, again, I go back to it takes a community, and that's what our collective, or Doula Collective, is about. We're community-based, and all of the money that comes in is either to pay doulas or serve families. There's not a lot of profit.
It's not a fee for service.
Yeah, there's not a fee for service.
So Tracy's program is not fee for service, but many doula programs are. So even in the pandemic, when we were deciding how many people were going to be able to be at bedsides, Douglas County Doulas wasn't up and running yet, and so we limited to 1, and there was a lot of push to allow a doula in, but we decided from a health equity standpoint, we weren't gonna let people that could afford doula care have an extra person and people who could not. And so it is often a fee for service. So that's another thing that I think we need to push for policy and have insurances covering doula services. To be honest, at LMH, we would love to have doulas there all the time, like have doulas on our birthing unit at all the time to be maternal support, but we don't get reimbursed for that. And so again, like, you know, Medicaid expansion, contraceptive care, lactation consultant, doula services, you know, these kind of ancillary support services that, you know, maybe aren't going to keep her from hemorrhaging, but may have her, you know, best family transition to the healthiest family possible, but they're not covered by insurance. So that's a policy avenue that I think we should all advocate for.
Real quickly though, I was going to ask, we do have a lot of providers, both medical and mental health providers in our audience. Do you have like certifications or trainings or anything that you recommend on perinatal mental health?
Yes. So probably the most common is through Postpartum Support International. So Postpartum Support International has several avenues. So if you're a peer person, community support advocate, wanting to learn more, they have a training for you. If you're a professional, they have an advanced psychotherapy and an advanced psychopharmacology training. And they also have a certification. So perinatal mental health certification. So that's something that anybody can get. Again, somebody who's just an advocate, not just an advocate, somebody who is a doula, somebody who is a lactation consultant, or somebody who is a prescriber or a therapist. So they have a lot of avenues for that. Mass General, women's mental health is a really wonderful go-to. There's a lot of leaders in the field in that regard, in particular from the psychopharmacology standpoint. So if you're a prescriber, that's something that I recommend. 2020 Mom is an organization out of California. They also offer free webinars and trainings. And for therapy, do you want to talk a little bit more about Karen Kleinman or?
Sure. So Mel started to mention Karen Kleinman. She's a very popular author in this area of care. Also runs some really fabulous workshops online. I recently attended over in Kansas City, Kansas. There's a practice called Sentimano that offers interval, like I think about 2 to 3 times a year, offers a comparable training that Postpartum Support International offers. Always best, I think, to connect with local providers to the extent that we can and build up that kind of wisdom as a community. There is a really cool opportunity if you're very jazzed about perinatal care. Next summer, Postpartum Support International will be hosting their international annual conference in Kansas City. So there will be a whole host of specialized conferences. You can pay to go for a day, you can go for multiple days, you can do the fast track if you want to take a deep dive to pursue the trainings necessary for the certification piece. So that's a really exciting spotlight on this part of the country.
One more thing, as Postpartum Support International is going to have the training here, and we've been really fortunate. Our Kansas chapter has received wonderful funding to support people to attend in this next calendar year, or next grant year. So that would include that conference. And so if you want to look to Postpartum Support International Kansas chapter, we will be putting information out about scholarship opportunities. So that would be a wonderful. And then Sentimano Counseling, their next training is in October, I believe, and then April. So if that's something that you're interested in, Mika Sentimano was one of the kind of pioneers in perinatal mental health in the Midwest, really. And their training does meet some of the certification requirements. So that would be a great alternative.
Thank you. Thank you all so much for coming tonight. We so appreciate you being here and being a part of this community conversation. And I do want to thank each and every one of our panelists. You guys are all amazing and doing this wonderful, wonderful work. So I deeply appreciate you saying yes to my many emails. Thank you so much. Now I'd like to invite Bert Nash CEO Patrick Schultz up.
Thank you so much. I am truly just blown away by your passion, your knowledge, your vulnerability and courage to share your experience, your personal journeys. After kind of a challenging afternoon, I was 100% re-energized and inspired by the work that all of you are doing, and you're coming up here and sharing with us all of this tonight. I probably share Stephen's, we're just humbled and just amazed. So thank you for that. Thank you, Merit Trust, for helping make this possible. And, we couldn't do this without our partnership with you, so thank you. We are seeing an increasing number of people come through our doors who are seeking that help. And I am so pleased that we have a group of individuals who are willing to help us spread the word and educate people. And I'm humbled by our staff who say, I want to learn more about this. It is such a prevalent thing. So thank you for being here. Thank you all for coming tonight and learning a little bit more about this. I am literally going to watch that video again and take notes next time and just amazing. And honestly, it is a problem when people talk. Because, yeah, there are times when we have to learn what we're requiring is really a dumb idea.
And he is great. I
Yes, he is.
Russ
Yes,
Johnson's very good, and he's a huge advocate for health equity, and he puts his money and time and
Yes.
energy and effort where his mouth is. But, you know, I'm kind of loose.
Yep. He and I are good friends, so I can trust that he and I can have that difficult conversation if we need to. So thank you again, really appreciate it. Please look for our next installment of this education series next May, and thank you all.